or post-herpetic neuralgia.
Continue.
Sir, Ali.
Dr. Manoj, please continue.
Okay, ma'am. So, the presentation is not much over. So, what is post-herpetic neuralgia? So, post-herpetic neuralgia is defined as burning or stabbing or shooting kind of pain, which can be constant or intermittent, affecting one or two or three dermatomes, usually one-sided, and usually pain persists for more than 4 weeks after the REMS onset, or maybe more than 3 months for post-herpes zoster. Acute is defined as when this pain is within 30 days. Subacute is 30 to 90 days, and post-herpetic neuralgia is usually more than 90 days, according to a paper in 2002. So, epidemiology, lifetime prevalence of herpes zoster is usually 20 to 30%, but it can increase up to 50% by the age of 15. Usually 5 to 15% of the patients of herpes zoster can progress into the post-herpetic neuralgia, and its incidence can increase with old age and immunocompromised patients. Risk factors include old age, pregnancy, immunocompromised state, lymphoma, leukemia. Others are autoimmune disorders like rheumatoid arthritis, SLE, COPD patients, diabetes patients, depression, asthma, smoking, and low socioeconomic status. Pathophysiology. So what happens is due to the viral reactivation that can cause inflammation of the dorsal root ganglion and sensory nerves, which can lead to the release of inflammatory markers like interleukin, and which causes the vasoconstriction of the nerves, which leads to the nerve ischemia and can progress into the peripheral sensitization and center sensitization, which can lead to allodynia and hyperalgesia. And patient might feel pain for long duration, which can progress into the chronic pain. So, management usually these patients first go go to the primary care physician, usually general physician or a dermatologist. So they provide first-line treatments like gabapentinoids, gabapentin, pregabalin. These are first-line treatments. Others are tricyclic antidepressant, SSRIs like duloxetine, lidocaine patch is which is available in 5%, capsaicin patch is like 8%. And in refractory cases, they refer to us for intervention pain management. There are many intervention pain studies which are available, but there is no clear cut which is more effective. So in this review article, they analyze all the interventions. So what they did is they record taken records from the PubMed, Cochrane, and MS through the online presentations, online articles, and they found out that the duplicates were 967, and they included only 19 studies, which were only randomized controlled trials or observational studies and case series. They have not included any case reports, letters, editorials, or conference abstracts. So they were excluded. They included in this study with adult patients with post-herpetic neuralgia, and which got in those patients got intervention pain management procedures, and they compared with other interventions like non-surgical, like medicines. And their primary objective was pain at fixed time points after the interventions, and secondary objective was quality of sleep using any of the reported questionnaires, analgesic consumption after the intervention, and functional evaluation and quality of life assessment after the intervention. Study, they used only the randomized controlled trial, observational studies, and case series. And interventions studied were intrathecal methylprednisolone, epidural steroid injection, interlaminar or transforaminal, paravertebral blocks or neurolysis, intercostal nerve chemical neurolysis, intercostal nerve and DRG, pulsed RFA, stellate ganglion blocks, and spinal cord stimulation. There were they found out three studies using the intrathecal methylprednisolone for treating the post-herpetic neuralgia. These upper two studies were done first one was done in 99, second was done in 2003, and they in both the studies the funding was there. So in both the studies, they found out that the more than 50% global pain relief in intrathecal steroid injection compared to epidural steroid injection, or methylprednisolone lidocaine group compared to only lidocaine group. But third study, which is done by the realistic randomized control trial in 2013, they found out that there was safety concern and some patient developed adenitis and meningitis. And in this third study, there was no funding. So might be in both other study also, because of the funding, they found out that the methylprednisolone patient intrathecal had got better pain relief. So it might be biased also. So in this third study, it was found out that the intrathecal methylprednisolone is hazardous, or it should not be used. Then these two studies were studied for intrapostal chemical neurolysis and epidural steroid injection. First was the observation studies. They included post-herpetic neuralgia patients for more than 3 months duration, and intercostal nerve chemical neurolysis was done with 50% alcohol under ultrasound guidance, and VAS scores came down to near 1 or 2 in all the cases in this observation study. Then another study which was retrospectively analyzed, there were 42 patients, 41 got interlaminar epidural steroid injection and one got transforaminal epidural steroid injection. Out of these 42 patients, 24 got moderate to good pain relief 2 weeks after epidural steroid injection, and 79% had persistent pain relief up to the 12 weeks. And post-herpetic neuralgia duration, which was less than 11 months, was predictive of moderate to good pain relief at 12 weeks post-epidural steroid injection with a positive predictive value of 55%. These in table 4, there were studies where pulse radiofrequency ablation of intercostal nerve and DRG were taken, and what they found out in all the studies is that PRF, pulse radiofrequency of DRG, is very effective, and patients got good pain relief after PRF lesioning when compared to the conservative treatment. And also when the also pulse even fluoroscopic guided intercostal nerve pulse RFA also got good patient pain relief compared to the sham group. Even with a pulsed RFA compared with the medicine group, also got better pain relief patients. So this table 5 compared the paravertebral steroid injection and chemical neurolysis and steroid ganglion blocks and RFA for post-herpetic neuralgia. For paravertebral blocks, was present in the patients with mood changes, sleep disturbance, and using all analgesic medicines, but patient was not getting relief. But after the paravertebral block, patient got good pain relief, and the requirement of analgesic was decreased in all the patients. And there were one study which compared the steroid ganglion block with steroid ganglion pulse RFA. Followed by for 6 months duration, and it was found out that the vast decrease in both groups and vast increase after 1 month in stellate ganglion group, and in stellate ganglion pulse RFA group was gradually decreased at later follow-up time points also. So they found out the stellate ganglion pulse RFA is better than the only stellate ganglion block. Then one other study where the stellate ganglion block was done, which was observation study. there were 34 patients had post-herpetic neuralgia for more than 1 year duration, and 8 had post-herpetic neuralgia for less than 1 year duration. And 65 steroid ganglion blocks were given in 42 patients, and one patient received 9 blocks. These were landmark guided, and anterior paratracheal approach was used. And in out of these patients, 12 showed no improvement, 11 were improved, and 19 had good results. And patients whose post-herpetic neuralgia was 1 year less than 1 year duration had better results compared to others. Then in this, there were studies also which compared spinal cord stimulator with continuous epidural blocks and sham groups. And in all these studies, they found out that the spinal cord stimulator is better compared to continuous epidural injection, where this post-operative neuralgia pain was refractory. In all the study was decreased, and but in one study there were adverse effects of spinal cord stimulator like hypotension and urinary retention was there, but otherwise in all the studies pain relief was good. Then the strength of evidence of all these techniques. Intrathecal methylprednisolone has very low strength of evidence, and it has very high adverse effects like tendinitis and meningitis can happen. And first RFA of intercostal nerve and DRG, and stimulate ganglion blocks and RFA as moderate evidence, and paravertebral steroid injection, chemical neurolysis, spinal cord stimulator, epidural steroid injection, intercostal nerve chemical neurolysis has low strength of evidence. If we compared with intercostal nerve neurolysis and epidural steroid injection, these are useful for post-herpetic neuralgia patients who have less than 11 months duration. And all patients usually got good relief with VAS can decrease up to 1 to 10. Because epidural steroid injection act on the dorsal root ganglion, and inflammation is usually present up to the 12 months in dorsal root ganglia. So epidural steroid injections and intercostal nerve neurolysis are more effective when we do this procedure when patients have less than 11 months duration of post-herpetic neuralgia. And these interventions have low complication rates. So, then dorsal root ganglion radiofrequency ablation. This pulsed RFA of the DRG reduces the neural hyperexcitability. This has moderate evidence, and this is also effective if the duration of post-herpetic neuralgia is more than 1 year. And this is safe also and minimally invasive also. Then one other study where paravertebral stimulant ganglion block were, and these are also effective when post-herpetic neuralgia duration is less than 1 year, and there is very minimal risk of pneumothorax in these patients. One other studies for spinal cord stimulation, usually based on weight control theory, it is effective for refractive post-herpetic neuralgia, and adverse effects are hypotension and urinary retention. So discussion of these all studies show that the post-herpetic neuralgia involves inflammatory and neuropathic mechanism. Inflammatory mechanism is more when it is less than 12 months duration, and neuropathic mechanism is more when it is more of 12 months, more than 12 months of duration. However, only few RCT are available. Most data are collected from the observational study, and it has been found out in all the studies that early interventions can improve the outcome of the patients. Clinical implication of these studies that the early referral to pain specialists can improve the outcome of all these patients, and we should tailor our intervention to the dermatomal level, and early intervention should be done, and we should combine the pharmacological intervention therapy as early as possible to get optimal relief. Take-home points from this article is that post-herpetic neuralgia requires multimodal and multidisciplinary management. DRG, RFA, and spinal cord stimulator effective for refractory pain, and awareness of the interventional pain management options are essential among clinicians, especially dermatologists. Thank you.
Thank you, Dr. Manoj. There were so many interventions, and you very well clubbed together. So we'll take the second presentation, and then we'll take up the questions which have been asked in the chat box and otherwise. Dr. Pradeep, can you share your
Yes, ma'am.
presentation?
I'll just do that, ma'am. Just give me a second. Is it visible, ma'am?
Yes. So Dr. Pradeep is DM Pain Medicine. He's presently working as a consultant in Department of Interventional Pain Management at Max Saket. So in the last presentation, you all saw the DRG and the spinal cord stimulator was the only intervention which showed the good evidence for the pain relief. So this presentation will show us the same pulsed radiofrequency of the dermatomal involvement by the spinal zoster. So Dr. Pradeep, you can start.
Yes, ma'am. Thank you for the introduction, ma'am. We'll just discuss this paper, which was published in Pain Physician 2024. It's on the efficacy of high voltage, long duration PRF. Now, as Dr. Manoj mentioned about CRF being performed quite regularly for PHN, but PRF is a little more, has been shown to be slightly better. Now, we'll be discussing a newer protocol for PRF for PHN in this particular study. Now, I have no disclosures. Now, talking about the background. So, we know the term Zoster-Associated pain, which is the new term which is currently being used for, which encompasses both AHN and both PHN. AHN is, of course, pain associated with the onset of the skin lesions, while PHN is 1 month or 3 months after the resolution of the lesions. Similarly, acute, subacute, and chronic phases have also been described in the literature. And as Dr. Manoj already described, the symptoms are generally neuropathic pain. It's persistent pain, radiating or tearing pain, and allodynia, sometimes accompanied by severe itching. PRF, as we know, is a safe, it is angle agnostic and does not heat the tissues to level that can damage it. Its effectives largely neuromodulatory in nature rather than ablatory, and the parameters have been the center for a debate for a very long time. Now, the usual parameters that have been used are 42 degrees Celsius with 45 volts and around 2 hertz frequency and a duration of around 180 to 300 seconds. But what we have found is that success of treatment is directly proportional to intensity of the field and duration of therapy. And intensity of this field will actually be dependent upon the voltage used. Now, similarly, something known as an HLPRF or high voltage and long duration PRF was introduced, in which the temperature was, of course, kept below 42 degrees Celsius. But a voltage of more than 65 volts was used for a duration of around 900 seconds, which roughly translates to around 15 minutes. So now the idea is that if you've read the Gauchi's book, in fact, the reason why the 42 degrees Celsius with 45 volts was kept as a standard was it was essentially the recommendation of the manufacturer. There was no real clinical rationale behind it. So we have now started experimenting with longer durations and both tweaking the voltage of PRF. Now, AHN with preventive role of for PHN has been shown already. Infraorbital neuralgia and herpes zoster ophthalmicus have also shown, PRF has shown excellent results in the same. Now, the reason why we did this study, the authors did this study, was how high can we go in terms of voltage? So we'll quickly describe the methods used. It was a prospective double-blind RCT. Recruitment period was around 8 months. Inclusion criteria was more than 18 years patients with unilateral spinal zap with VAS more than equal to 6, refractory to or unable to tolerate side effects of usual pharmacological line of treatment. Exclusions included non-consenting, coagulopathy, poor general condition, etc., like we all usually exclude. But I would like you to note this particular thing, vast more than equal to 6, because it will be crucial while we'll be critically appraising this study. So, of course, a 16 slice CT was used. As you can see, as we all know, we target the posterior superior edge of the intervertebral foramina. So we reach the DRG, we stimulate the DRG and see uh, how we are doing. And this was the pulse generator G4 Cosman used, which allows us to also regulate the voltage. Now, the time points were T1 through T7. T1 was the pre-treatment or the baseline. Day one after initial treatment was T2, and before the second treatment. So this study, I'll explain further in the consort diagram. They did two interventions, 1 week apart. So T2 was day one after the first treatment, while T3 and T4 were day one after second treatment, and T3 was before the second treatment was done. So when the patient was wheeled in for the second treatment, we checked VAS both at two time points, one initially while wheeling it, after the second intervention. And of course, then we had 1, 4, and 12 weeks at T5, T6, and T7. So this was a little complicated time points that they used. And outcome measures, the VAS at 12th week or T7 was the primary endpoint. Secondary outcomes were VAS at all the time periods, brief pain inventory at T1, T5, T7, GARD 7 for anxiety was checked for T1 to T1 and T5 to T7. POSKI looked at the sleep quality of the patient, and it was again measured at the similar endpoints, and medication usage was also measured. So for sample size calculation, they used a software called PAS 15. Alpha was kept at 0.05, power per was 0.80. They kept a 20% drop rate, and the final sample was 28 per group. But they ended up screening around 62 patients. They were randomized using Excel spreadsheets. They divided equally into two groups, Group A and Group B. It is important to note that it was a blinded experiment with concealed envelopes used. After each in Group A, essentially what they did was they started increasing the voltage of the PRF from 65 volts, and they progressively kept on increasing it to the maximum voltage of less than equal to 100 millivolts, while 100 volts. While in Group B, they kept the output at the setting of 65 volts. They did it for 900 seconds, and after the completion of the setting, they gave a 2 ml lidocaine, 2% with cobalamin shot with a compound betamethasone injection, which they define as betamethasone dipropionate 5 mg and 2 mg of betamethasone sodium phosphate. So they combined the entire thing and they injected it along with some NS. In the follow-up period at 1 week, the entire procedure was repeated. As you can see, there was a dropout rate of 2 in the Group B or the standard study arm. So, talking about the results, the baseline characteristics did not differ at all. The VAS was significantly better in Group A than Group B, but even though the p value was quite significant, you can very well see the raw data as well. In quality of life rating, patients showed significant improvement with Group A, which was a higher voltage PRF, and it was, however, only significant at T7 or at 12 weeks. So even GAD7 and PHQ9 showed similar endpoints, with T7 showing that is at 12 weeks showing a significant improvement in Group A, and both at 4 and 12 weeks PHQ9 showing a significant improvement in mood. POSQI also improved with group A, and the results were quite significant. Drug use was also lower with group A, but the results were not statistically significant. ADRs were not there. Practically, hospital cost was equitable between the two groups. Now, discussion for this is quite straightforward. Improvement was seen across both primary and secondary endpoints at both in the both groups. HLPRF was consistently shown to be more effective. Multidimensional functional recovery was there, which shows that this is a superior modality, and no ADRs with voltage escalation showed that this HLPRF is actually safe. Now there are a lot of problems with this study, so we'll just discuss it point by point. And the problem is that this is something that we have repeatedly seen with most of our interventional pain trials. So we need to be very careful while designing a trial and see that we are doing justice to the study. Now, the first of all is sample size and design. Now, they have used a software called Pass 15, but they have not told us what things they entered in that particular software. Without the inputs, the output is meaningless, and this limits the reproducibility of the trial. There is something known as Cohen's d or effect size. It was not at all reported anywhere. It is crucial for us to again reproduce the trial. Now, there's another concept called minimal clinically important difference, which I'll just demonstrate it here for your for the completeness sake, that VAS is has been shown to be 3 in group A and 3.5 in group B. The result is statistically significant. However, it is not really the difference is not much. 2 in 3 VAS is there's not too much of a difference there, but the statistical significance is present. So this is where the concept of minimum clinically important difference comes, where which helps us power the study according to a clinically relevant data and not just on statistically significant results. And of course, no superiority margins were defined. We have not been told whether this was a non-inferiority trial or a superiority trial. So, which is again eats away into the power of the study and makes sample size less reliable. Now, another problem, it's a huge problem that I've seen again and again with our studies, is VAS was used as a categorical variable. Please remember, VAS is a continuous variable. You use 0 to 10 centimeter or 0 to 100 VAS. It's a continuous. So 6.1 and 6.3 are two different VASs, even though they might not be clinically important, difference might not be there. So they have misclassified VAS as a categorical variable. They probably wanted to use NRS, so this is methodological misclassification. Dichotomization of categorical data absolutely destroys the power of the studies. And there has been nowhere they have mentioned whether the data was normally distributed or not, and nothing like that was shown. So, in light of these things, t-test and Man-Whitney that they've used is erroneous. They should have used repeated tests like ANCOVA, analysis of covariance, and corrections like something known as Bufferoni is required when we are using multiple tests. Now, I'll tell you what multiple tests I mean. When we are doing repeated measures between at different time points between the group and across the groups, we are actually decreasing the power of the study. So the number of tests we need to divide the alpha, whatever we are assuming it to be, and divide it by the number of tests that we are doing in order to come at a clinically meaningful endpoint. So that has not been shown, and it really overpassed the alpha. And how were the dropouts analyzed? Whether there was an intention to treat analysis or whether it was a per protocol analysis, it has not been mentioned. So take-home message will be HLPRF has been shown to be superior to usual voltage and duration ranges. It is safe and it is not associated with adverse reaction. However, we need better studies. They are the need of the hour in pain medicine, and strict adherence to both impact framework with statistical frameworks is needed. Thank you so much.
Thank you, Dr. Pradeep. So for faculty, we have with us Dr. Ashu Jain sir, who is Chief of the Department of Pain Medicine at Atter Hospital. and Krishna Poddar ma'am, who's our president, ISSP. Welcome, ma'am. So we can take up the questions which have been asked. Capsaicin, we have taken up these questions in multiple journal clubs that it's not available in India. And one of our participants has answered that as well. So another question is...
And one more thing as well, capsaicin I have used before. It is really very, very burning pain. My patient normally cannot tolerate it.
Capsaicin?
So, yeah, I have used it a few years back.
Okay.
Not patches cream, but very concentrated.
Okay.
But it was so much painful. Patient really doesn't want. When it's burning, so much burning.
Probably not very user friendly. So the question is, are there chances of reactivation of virus after epidural steroid when safely they can be used without fear of reactivation of virus due to steroids? I think because epidural steroid has been used in the post-herpetic neuralgia, so they're asking if you use steroid again, there will be reactivation. I haven't seen any second case of herpes zoster on top of when the patient is already having reactivation of herpes. Krishna ma'am, your take on that?
Yeah, no reactivation of virus because of the epidural. I don't know, but sometimes it happens with the disease. Reactivation of virus means people can have the relapse. I've seen one or two patients who has herpes zoster, then they recovered, and next they again have. It can happen. Yeah.
With different dermatome.
One more thing, I think.
Epidural steroid immediately.
No, after epidural steroid, not. But after epidural steroid, really, I don't know, it's not really work so much.
No, the
if
important...
it is the initial stage, initial stage, okay. But post-herpetic, it doesn't work. Second thing is their antiviral treatment, they have not mentioned it. It is important because from the primary healthcare physician or from the pain physician, have they received antiviral treatment or not?
Actually, ma'am, good evening.
Good evening.
Actually, whatever we do in epidural steroid, our dose is too less as compared, to decrease the immunity and causing reactivation of the virus. So I don't think that is a concern. And it is more of a concern in acute rather than in a chronic one when already we do epidural steroid and do continuous infusion for acute pain management where dose can be high. But I don't think there is any study which shows that with our dose that we are giving in single nerve root or maybe at the maximum in herpes at 2 root level, we are injecting that much of steroid that in a chronic case, PHN, there will be activation. I don't think that is the case.
No, there is no activation. No studies are available like that.
Yeah.
And then what about steroid injection in diabetic patients?
Epidural steroid, safely you can give. That's not an issue because we are doing for other MIPSs, spinal MIPSy, epidural steroid, transforamen steroid. Again, as Ashu is saying, the doses are small. And in fact, I always ask all the diabetic patients to have the regular sugar checkup after the epidural. One or two patients, they have shoot up. Otherwise, not really.
It's not a contraindication. We can reassure patients that the blood sugar might increase for next few days, and then you have to monitor it. But having a diabetic patient,
yes, that's all.
It's not a contraindication for it.
No, like in our post-op advice, we have a printed advice. In printed advice, we have mentioned that if you are a diabetic, after our intervention for next 7 to 10 days, please check your sugar at least alternative day because it can cause transient increase in your sugar. And that is all, not more than that. So they have to be careful. And if their pre-op sugar is well controlled before intervention, mostly we are okay with that. So That should be the advice, that it is controlled pre-op, and secondly, and then they can for a week, not more than that it is required. At least on alternate day, they can check a fasting sugar, and that's all. That should be all.
For how long can we give duloxetine or any antineuropathic agents for post-herpetic neuralgia or herpes zoster-related pain? I think it depends on the duration of for the how long the patient is having pain for. You may taper.
Yes.
Dr. Pradeep, do you want to say anything? What's your protocol and your?
Yes, ma'am. Ma'am, regarding the neuropathics, the problem is particularly with duloxetine. It is not, it's very easy to start that drug, but it's very difficult to stop Symbal or stop duloxetine, because what is usually recommended is if we have gone up to like 30 or 40 milligrams per day of duloxetine, we must try to taper that drug off over years. So it becomes a program of years, not of a few weeks or a few months. Secondly, another thing I would like to reiterate over here, which is a common thing that I've seen in a lot of prescriptions, is please prescribe duloxetine as a morning dose, not as an evening dose or a night dose. Duloxetine actually, its pharmacokinetics is such that its absorptions goes down significantly as we go down the day. So please do it as a morning dose. And of course, regarding gabapentinoids and pregabalin, we have a very variable systems, and we need to take into consideration the patient's acceptance for the same. But in general, please prescribe, if you're using even 300 milligrams of gabapentin a day, please prescribe in divided doses of 100 milligram each throughout the day in a tedious dosing so that you can maintain the plasma levels. That's all, ma'am.
How did they give lidocaine, betamethasone, and methylcobalamin combination route of injection after PRF?
Not taken, heard first time. What is the safety of injecting a multivitamin preparation around
No
that?
idea, sir. It's very strange
It's a
that they
very
have done.
weird thing
Yes,
that
sir.
it has been told. So,
No, in most of the center in US also, I have seen they give magic drip type. They give, they mix up so many things and give.
Very strange for us.
Multivitamin, vitamin C, B12, glutathione, then NADCell. I know many centers they do this for neuropathic pain.
Even the compound betamethasone injection was, I mean, I could not understand the logic behind combining two different salts of betamethasone in one go, and I don't know. I did not understand that, sir. And I tried connecting with the authors for
Have
the
they
same. I did not
explained
get a
anything
reply.
about it? Have they explained anything about it?
No, nothing has been explained. I even connected with the authors. I put them an email, but they have not yet responded to it.
Okay.
So, what's the reason for statistically significant pain so late?
I did not understand the question. Sri,
that is after 3 months. What's the reason of statistically significant pain so late? I mean, earlier also they had.
Ma'am, probably between the groups, they have shown that statistically significant relief was there. But what we have seen usually is if your treatment protocol is more effective between two arms, generally the statistical significance diverges slightly. But again, it was just significant on paper. Like the critic was, it was between 2 and 2.5, 3 and 3.5. It was not clinically meaningful. So statistics can lie to us with quite significance at times. So that is the main problem.
रास्ते में मेरे को मतलब निकले तो फोन किया था 15-20 मिनट पहले.
Who is talking like this in between the lecture? We can stop them.
Please mute everyone. Mute.
Yes, I've muted them.
Please mute yourself.
Yeah, I have muted them, and suddenly it's like I've muted everyone, but some of them unmute themselves in between. All right, Dr. Manoj, do you have to say anything about any of the papers you said or epidural steroid
Ma'am, one thing I want to add that they use pulse RFA, not conventional RFA, Dr. Pradeep. They all use pulse
Okay.
RFA.
Okay.
And
Right.
all
Right.
the
Right. Right, sir.
uh,
All right, sir.
and one more thing, ma'am, I want to add that
Hmm.
early intervention can make a difference in all the patient of post-herpetic neuralgia. In all the studies, they found out that the patients who got intervention within 1 year, they got better results and better outcome compared to patients who have post-herpetic neuralgia for more than 1 year. So they become more refractory.
That's fine.
So there are certain things that I want to talk about this management and intervention.
Yes,
First, we should sensitize our skin colleague to, start neuropathic medicine with onset of this uh, lesions, because as it is mentioned, the more early we start neuropathic medicine, the chances of getting PHN will be less, and even the severity will be less. So that is one thing. And I have seen so many patients who are referred that dermatologists have not started this neuropathic medicine early. Secondly, targeting dorsal node ganglion is always a better solution than targeting a peripheral nerve. That gives a very good pain relief. If we can do conventional RFA, that is good. Otherwise, long duration or slightly higher temperature like 45-degree or high voltage will be a better solution.
But
So,
DRG, you can't do a conventional RF, Ashu.
sir, madam, we can do conventional RFA if we can have a differential sensory and motor. Like I tell you, if it is in thoracic area above
Thoracic.
T8, it is thoracic area above T8, and then and it is unilateral at 2 level. We will always do this conventional RFA, because that is not going to affect the motor part, because PHN is only maximum 2 segments, no? Otherwise, maybe 1 segment at the maximum. So otherwise, high voltage PRF, like we do at 45-degree, and for 600 second, and very good results. On the average, 3-4 years, maybe 5 years
Yes,
sometimes.
yes.
Very good result, madam. But we should always try to target DRG rather than doing a
Yeah.
peripheral now. And doing alcohol neurolysis in a peripheral nerve is not a, it's a not a good idea.
No, no, no.
We should
Different
not try to do
modalities, I
that.
think, yeah, with different modalities,
So it is better that even if you are it is a difficult situation to do thoracic DRG, in that case we can do intercostal now. But as I told you, if it is a single or two nerves above T8 and not involving the abdominal muscle, you can do conventional or pulse, high voltage or high temperature 45 is a better solution rather than doing alcohol neurolysis in case of.
Alcohol you should not do.
Yes, yes, yes.
Nowadays, at least, when you have the better. If you have
And
RFA, you should not do, because
yes,
of, other than the cancer patient, if anything happens,
yes, yes.
sometimes alcohol is very notorious. It can increase the pain.
Even then, it is not a good idea, to do alcohol neurolysis. And if you are doing trigeminal, you can easily do conventional RFA. Like the sympathectomy, you can do conventional RFAs. Stilet, you can do conventional RFAs. So wherever you can do, but targeting DRG is a better approach rather than a peripheral nerve. So this is what I think is good, and all from my side.
All right. Thank you, sir. Thank you, ma'am. So just few things I want to tell. For our next interesting case discussion is on December 4th. That will be from AIMS Delhi and Gangaram Hospital. And our next JC will be on December 19th. So I'll encourage everyone to join our national conference, which is in Hyderabad this year in February. And also, the Mumbai Pain School is organizing a workshop in May. If anyone wants to attend that, just message me and I'll send the details. And if there is any one who wants to present in this journal club, they can also message me. I'm typing my number, and just let me know if they want to be a part of the group and wants to present anything.
Yeah, they do na.
Again. So Anyone who wants to say anything or raise their hands, they're most welcome. Otherwise,